are absolutely thrilled to have Dr. Helena Lydon doing this next presentation. She is a Chartered Behavioural Psychologist and a researcher and lecturer at the University of Galway. She is also the director of the Applied Behaviour Research Clinic, offering specialist interventions on sleep and feeding. She has over 15 years of experience working to support adults and children in disability services across Ireland. Her research on the application of behaviour analysis to a broad range of areas includes reading interventions, staff implementation of positive behaviour support, and social skills curriculums for employment and social inclusion. This presentation, Helena will discuss a number of projects she's been involved in, which focus on the use of virtual reality as a learning tool. And the title for today, you can see on your screen in front of you, Can Technology and Behaviour Analysis Work Together? Applications for Acute Chronic Pain Experienced by Autistic Children. And Helena, I have a link for a YouTube video. Will I post that into the chat now?
Yeah, you can post it. It's just I'll make reference to it later on. I tried to embed it within my talk, but it was causing some complications. So I just said I'd give people access to it.
Yes.
It's the easiest way.
And and we'll just ask people not to play it until you're ready to discuss it, or is it just for reference?
Yeah, it can be just for reference. I've indicated what, which section of it is relevant for the talk.
Lovely, thank you very much.
Yeah, when I'm in my kind of presenting mode, I'm not able to see the responses to the poll. So I'll, I suppose my first poll question, I think, was just to ask people how, I suppose, from the people in attendance, have people are they currently supporting anyone that is experiencing pain, or have they in the past? So I'd be curious to know what kind of experiences the audience have had. I don't know if we can just give like a yes or no response, or people can.
Yeah, we can throw that poll up, and if would you like me to stop you in a few minutes, or would you like to? We can also look at it at the end of the.
Yeah, I'll pause in a few minutes, and you can let me know.
Great, thanks, Helena.
Okay. Great. So good afternoon, everyone. Firstly, I'd like to just commend ISBA for establishing this community event. I think it's a hugely important event, and I think evident by the huge interest today, hopefully it'll be a long-standing event in our diaries every year. I'd also like to thank them for inviting me to present alongside so many fantastic presenters today. So today I'm going to base my talk on kind of one strand of research that I've been working on over the last 6 years. Today I'm going to be speaking a lot about one lady, Rachel Fitzpatrick. So she's been heavily involved in a lot of this work. She had originally started doing some work on her placement around preparing individuals to support them to attend medical appointments. And it was around this time that she also was embarking on her master's thesis. At around the same time, I was doing a lot of research on social skills and communication, and we found a shared interest in the area of pain and pain communication, and we found that there was very little research in this area to support autistic individuals, and particularly for individuals who had issues around and challenges with communication. So just to give people some context of what I'm talking about today, because for some people, pain is a whole new area. So I will refer to pain, but broadly there are two categories of pain. So there's what we refer to as chronic pain. So chronic pain is when someone's pain is persistent and reoccurs for longer than 3 months. So at that point, after 3 months, it's deemed to be chronic. Acute pain is probably something that we're more familiar with. So it's pain that happens suddenly. It kind of has like a quick start. It can be sharp and intense and serves to warn our body that either it's in danger or the presence of disease or harm being done to it. So acute pain, things that commonly happen are like injury, surgery, illness, or a painful medical procedure, which we'll talk about again later. It's typically shorter in duration, and it usually subsides relatively quickly or with appropriate treatment. So for individuals on the spectrum, we see that they may experience pain differently. The International Association for Pain have made statements that they do believe that obviously all individuals experience pain, even if they're unable to communicate it verbally. And again, we need to consider other factors, such as that people may express their pain differently. And we also need to look at particularly individuals, if they have co-occurring intellectual disabilities, how this may impact on their ability to express their pain. So it's been found that children with on the spectrum can show higher rates of pain compared to children without autism spectrum disorder. And also individuals with intellectual disability, the rates are particularly higher. So the general population, they say, is about 10%. And you can see that in the first comparative study where it was like the children without ASD had 8%. So that's very close to the national average, which is 10%. But again, in individuals who present with a co-occurring intellectual disability, that can be as high as 50%, which is very high. And again, there's some new literature to indicate that maybe pain intensity is higher, experienced higher, or also there's a less adaptable, people on the spectrum may be less adaptable to the sensation of pain. So therefore, we need to consider how we can best support them. So at this point, it would be useful to kind of get an idea of people's responses to the first poll, if we have it.
Yes, so far we've had 9 votes. So I would just, if anybody else would like to vote, you just go down to those symbols and you'll scroll down to the bottom. And the question is, are people currently supporting people experiencing pain? So we've got 14 votes for yes and 4 votes for no. So there are quite a few on here.
Great. Yeah, so the next study I'll just refer to, so we kind of wanted to know in the Irish context, like what is the impact of pain on those that experience the autistic individuals and those that experience co-occurring intellectual disabilities. Again, some of the literature excludes people with co-occurring disabilities, and that's been a shortcoming in some respects because obviously there's across the spectrum, there are people with varying needs and we want to make sure that we represent them all. So as part of Rachel's PhD, we did undertake a carer survey based on to look at different aspects of pain. So we wanted to look at the presentation of pain and its frequency, also factors around their pain, how they communicated their pain currently, as well as limitations or the impact it has on their treatment and healthcare they receive, and also kind of any pain-related decision making. So it was a postal survey. We had links with kind of 5 care providers nationally, and it was also posted on a number of kind of online social media forums. It was open to caregivers, which included like parents, but also care staff who work directly with an individual. And an example might be like a key worker or a social care staff that cared for somebody in residential services. We felt that this was important to try and ensure that we captured people across the lifespan, so maybe older adults who might be residing in care. Again, we wanted to look at this kind of like holistic element from everything from their demographics, so what kind of age profile of we were having represented to the types of pain they were experiencing. So again, were people experiencing chronic pain or more acute pain? And whether we felt that there was a correlation, or if we could establish if there was a clear correlation between challenging behaviour and the 2 forms of pain. We were also interested in looking at their locations of pain. So they were asked across 10 body parts where they were most likely to experience pain, and then what severity of pain they experienced in that location. They also reported on their current health problems and also on the impact that the pain had on their daily functioning, as well as some information on their healthcare. So whether they currently attended their medical appointments, whether they were able to communicate with their healthcare provider, or whether they were involved in decision-making in their treatment. So again, we had a large number of responses. So we had over 200 people, caretakers, participate in this study. Of those that they were responding on behalf, 57% were male and 43% were female. And 86% had a co-occurring intellectual disability. Again, the age range was quite broad. So we had everyone from 5 to 70 years of age. Again, we did see a high level of experiences of chronic pain. So again, 35.6% had chronic pain, which lasted at least 3 months. And of those, 34% felt that the pain was always interfered with their quality of life, which indicates to us that there's quite a high impact of this on the individuals affected. 70% Their carers reported that they felt the person they supported was able to communicate their pain, but we were quite interested in the methods that people were using. So our largest proportion was behaviour change. So it was a change in someone's behaviour that indicated to their carer or their family member that they were experiencing pain. Some indicated that they were able to vocalize their pain, and they were, overall, it seemed like quite a high proportion, but when we broke them down, only 12% were able to fully vocalize that they were experiencing pain, whereas 30%, it was some partial vocalization. So maybe they used a word such as sore or tummy or ouch to give an indication that they were in pain. And were able to point to the body part that was affected. But you can see there for 18% of individuals, it was actually they were relying on something like a change in facial expression. So that was something maybe very subtle that needed to be picked up by a caregiver and also interpreted correctly that it was pain. So again, the health problems, people will probably be very familiar with them. That so again, things like gastrointestinal problems, disturbed sleep, maybe as a side effect of their pain, dental issues, epilepsy, feeding issues, and also gynecology. So we had a number of the female respondents, maybe things like menstrual pain were issues that were contributing to their pain. The pain itself was found to be having an impact on their concentration, their mood, and their sleep. So again, affecting a number of aspects of their life, which, you know, are seriously limiting their quality of life. And again, 34% reported that the pain was actually interfering with their enjoyment of their life. Some of the information on healthcare treatments was very interesting to us because there was quite high rates of individuals who were actually never involved in the treatment that they received. So they would, in some instances, maybe never even attend the appointments. So again, you see there 60% never actually even managed to attend appointments, even when given support. So maybe someone would represent them at their appointment. So these are all issues that we want to look at and make sure that we can try and encourage and support people to be more active and present at their medical appointments. Again, 66% were unable to take medication without any intervention, and only 2.9% were taking medication correctly and independently. So again, relying on a lot of support in relation to ensuring they receive the appropriate treatment for their pain. And again, with respect, communication was a repeated issue. So again, very low percentages were able to report pain independently. And again, of those that we asked, were they able to actually ever request or report pain? High levels that had never reported pain independently or never asked to see a doctor or a nurse when it was required. So again, all of these factors were really important to us, and we needed to consider a lot of them in relation to how we can support people to access appropriate healthcare and be more actively involved in their healthcare. Kind of in parallel, we undertook a systematic review. So we wanted to look at what assessment methods are there for the identification of pain in people on the spectrum. So we felt like, you know, were there appropriate tools, and are they tools that are available and accessible to those that support them? So as part of the review, we identified 11 pain assessment tools used with individuals to rate the intensity of their pain, and also kind of things like the kind of impact it had on their behaviour. We found there was an increase in objective measures, so things like heart rate, facial coding, MRI, things like that. They were emerging kind of technologies. However, a lot of these measures are not available like within a school or within a day service, so they may not be useful daily measures of pain. However, the non-communication children's pain checklist was found to be the most commonly used. It had good kind of psychometric properties, and it was designed to be easily delivered by or completed by a parent or caregiver. It didn't require any formal training. So as a result, we felt it was a valuable measure that could be used, particularly to support individuals who weren't currently able to communicate their pain. However, we do have to have some kind of caution in its use, because obviously it is completed by a parent or a caregiver, so it is subject to some reporter bias. So at this point, I suppose we felt like we were faced with like a big challenge. We know individuals on the spectrum experience pain. We know that there's, for some individuals, particularly of those that we surveyed, there was a number of individuals that weren't able to communicate their pain, so maybe presented as nonverbal or limited verbal ability. So we kind of wanted to set about like looking at things like and focusing on what they needed to communicate and how they needed to communicate, and also the learning opportunities or how we could create them. So this is where we felt our solution might lie. So we thought that things that they needed to communicate is they need to communicate that I have pain, where I have pain, and what I need or what I want, so as in pain relief. We thought about the learning opportunities. So again, if we think about other types of communication training, what we want to create is we want to create motivation for the person to communicate. So if we're doing other forms of communication training, we might be looking at things like their preferred items. And we know that they're going to be motivated to maybe ask for those items. However, in the context of pain, motivation is greatest when pain is experienced by someone or when it's worse than usual. Thus, that creates the motivation for the person to ask or to seek help with their pain. So in order to explore ways that we could do this and how we could go about teaching, we had to consider a number of issues. So the biggest challenge was that we couldn't actually initiate pain. We couldn't cause someone to experience pain. So we had to think about how are we going to like ensure that we have the motivation to teach pain. So this led us to Rachel's master's thesis. So in this study, we wanted to look at how we could actually teach pain. So it was like kind of an intervention used to teach children that had co-occurring ASD and ID about their pain, to communicate the pain, its presence, its severity, report the location, and then also teach them to request pain relief. So we were very delighted that this paper was accepted for publication. And in response to its, I suppose, being made available, we've had a huge number of requests about this study and how we went about teaching the protocol. So in response to this, we're currently actually working on developing a handbook as a training protocol, and we hope to make it freely available on our website in the coming months. So if anybody's interested in that, you can either reach out to me after today's presentation and we can add you to our mailing list, or there's some information about our research group at the end of the talk. But again, like I said, I suppose for us, we felt it was a really under-researched area, and we recently heard, I think 2 weeks ago, from the publishers that it was actually the most downloaded article on their journal for 2022, because they they recorded the highest amount of downloads, which again shows us that like this is an area that people really need to know how to teach. And again, from the emails that we're receiving about from people, like there's a huge, it highlights a huge area of need. So in this particular study, we had 3 young men that took part. They were ranging in age from 11 to 12 years. And when we took baseline, so we used that measure that we found from the systematic review that was the most kind of used measure. And we actually chose to use a version of it called the post-operative version. So this is typically used post-surgery for some children. But we felt in this case it was the most appropriate one, because the standard one asks you things like about sleep and questions like that, and they weren't particularly relevant in the middle of the day because there was no impact on sleep at that point in the time. We found the measure itself that all of the boys were actually scoring quite high. So the measure itself has a threshold of 6 to indicate they're in mild pain, and 11 to indicate that you're experiencing moderate or severe pain. And based on baseline scores, these were all experienced in 18 to 22. So those scores were way surpassing to show that they were experiencing quite high to severe levels of pain. So like I said, we took that pain measure. We also took measures on their challenging behaviors, so just like kind of frequency of kind of instances of behaviors. And we also took data on their pain communication. So whether they could point to the Wong-Baker pain faces scale and show us the amount of pain they were experiencing, if they could vocalize the location of their pain, if they could request pain relief, and again, if they could make independent initiations. We taught a series of components. So how we based this, or what we based this intervention off, was Pate et al. So they had developed, or they had kind of looked at the concept of pain and how it develops in children. And they felt that it emerges as like my pain and like identifying related knowledge about pain, then a child getting an understanding of pain in the world around me, pain in me, so my own experience of pain, and then also communicating my concept of pain. So we wanted to try and mirror this in how we structured the kind of instructional sequence. So I'll just take you through each of them. So basically in component 1, participants were, we tried to identify if the participants could label body parts on an iPad, or you could replicate this even using a simple like sheet of paper with a body map, and asking them highlighting a component of the body, so something like the head, and they would, once an element of the body was highlighted, they were asked to identify that. So they'd refer and say that it was the head. So obviously we did this for a number of body parts. What we found for these participants is that actually when we checked for each of the participants, they all scored like very highly on this. So they actually had this skill when we probed for it at the outset of the study. Second, individuals were asked to point to and label the body parts on themselves. So we wanted to know that they also had that skill. So again, they were simply asked to point to, do you know your arm? And they would point to their arm, and then they would also be asked to label that part of their body. In a similar fashion, we probed this, and we also found that the participants had this skill at the outset of the intervention. And then we moved on to component 3, which was that we wanted to teach them about the kind of the sequence of pain. So we presented them with 5 scenarios that presented painful experiences for other people. So the 5 scenarios that they were taught about were falling off a bike, getting injured while playing football, hitting their head against a door, falling off a swing, and burning a hand while boiling water. So again, you can see in the slide, there's a list of the kind of visual sequence. So the 3 slides or 3 images that they saw. So if I just take you through the visual of the sequence of the bike. So they'd see a boy on his bike and he was smiling, so there was no pain present. The boy would fall off his bike and was on the ground, and the boy was crying, and there was a visible kind of cut or something to his knee. This is what they saw in the component 3. And then later on in component 4, they became aware of the pain relief option. So a Band-Aid or maybe a cold pack or an ice pack was offered as the treatment option or the pain relief. So basically what this looked like was they saw the first 3 images in the sequence during component 3. And during this teaching component, what we asked them was we asked them a number of questions. So we were asked them, you know, how does he feel at the start of the sequence? And what we wanted them to indicate on the pain scale was that the person was happy or experiencing no pain. So we would expect them to point to the kind of the green face or the happy face. And then we were asking them what they were doing. So we're just making sure that they had a comprehension around the issue. And then what happened. So he fell off the bike. And where does it hurt? So we wanted them to say the leg or the knee. And then how is he feeling? So at the end of the sequence, we wanted them to report that they were in pain. So again, we wanted to ensure that we were able to get accurate responses for no pain present in picture 1 and pain present in picture 3. And component 4 was just that addition of the other element of the sequence. So you can see from our results that we, in this image, it was the data that we had on challenging behaviour and their score on the pain scale. So the lower line, the dashed line that goes horizontally, it indicates that was the lower threshold for mild pain. And then the upper line is the line which denoted whether they reached a score of moderate to severe pain. So you can see for all three participants, they were experiencing mild to moderate pain on a daily basis. So it was there every day when we, and in particular, when we saw higher instances of challenging behavior, we often saw higher levels of pain. So again, when it peaked here, and so on and so forth. So we saw this merge across for the participants. What we also recorded was their communication of pain. So one thing of interest to us was that, like I mentioned, when we probed for the skills, all the participants had component 1, which was tested for here, and component 2, which was probed for here. But you can see during this time, they didn't actually engage in any pain communication. And the pain communications that we were looking for, you can see them later on in the on the graph, but the black bar detects when they pointed to the Wong-Baker pain faces scale. The grey denotes when they requested pain relief, and the white denotes when they vocalized the location of pain. So interestingly though, even though all of these individuals could actually, at the outset of the study, could identify body parts on the iPad, and they could label and point to body parts on themselves, but despite having these skills, they never actually communicated the presence of pain, the location of pain, or requested pain relief. It was only after we taught component 3 for participant 1 and after we taught all 4 components for the remaining 2 participants did we see an emergence of the skill. Again, you can go back between this slide and the previous one and see that most of the occurrences of the pain initiations were when they experienced kind of more higher to moderate levels of pain. In these instances, if the pain scale indicated that pain was present, the staff would ask the person, how do you feel? And in response to that, they would point to the Wong-Baker pain faces scale to indicate that they were in pain, or they would point to a visual cue on their table to indicate one of the types of pain relief that they wanted at that point in time. And the white bars also, they may have just said like arm or something or leg was sore. So again, it showed us that all 4 components of the skill were required to kind of ensure that someone had adequate skills in order to report and request pain relief. Okay, so I suppose moving on from that study, one of the things we took from that study is that we had the scope and the potential to teach pain communication. And we felt that it was an appropriate intervention and that it could be achieved, but we felt maybe its capacity and our capacity to deliver it as an intervention was limited to like small numbers of individuals. So then we wanted to look a little bit more about like how could we deliver a broader intervention and use maybe kind of technology to assist us in doing that. And what we were interested in looking at was kind of like the delivery of treatments for chronic pain. And there was some kind of like emerging kind of interventions in this area that we felt maybe that would be a good starting point to look at this. So we wanted to look at kind of psychological and behavioral interventions around chronic pain. So again, when people are experiencing chronic pain, they obviously have to learn to live with the chronic pain, because for some people, there's no kind of cure to it and no resolution. There's a need for them to develop kind of psychological strategies to change their experience of pain and learn ways to kind of live and pursue kind of their goals and an increased quality of life by trying to control their pain. So within the University of Galway, there had already been some well-established research conducted by the Centre of Pain, and our colleague here, Professor Brian Maguire and Sharon McManus, had actually developed a CBT curriculum, which was originally designed for people with intellectual disabilities as a pain management programme. So it was delivered as kind of like a hardbound book that you could use as a manual, and there was modules and kind of content they had developed. So all again, really rich and valuable content. That manualized version was first developed in 2010, and then it was evaluated with adults with intellectual disabilities and also with young women that experience menstrual pain. And following on from that, it actually had been adapted to an online intervention by a PhD student called Angeline Trainer. And again, she had evaluated it with typically developing children and found it to be effective as a pain management intervention. So what we were really interested to see was, like, could we take this pain management intervention and adapt it and make it accessible to autistic individuals? So what about it was good, and what could we keep, and what did we need to adapt? So again, this research fits within Rachel's PhD, and she's looked at and undertaken a number of interviews with families, both parents and children, to gather their views around their experiences of using the online intervention. So all of the participants reviewed and all the content. So in the current Feeling Better, there's 9 missions, and they completed a number of questionnaires and interviews after each kind of set of modules, and gave us their feedback on ways that we could improve the online intervention. So this just shows people some kind of the screenshots from the original curriculum and how it was kind of laid out and structured. And we got some really, really rich information from some of the families. So things around the structure of the content, how interactive it was, and also maybe the theme of the program. So they did like the pirate theme, but again, maybe options to maybe personalize your character or select features of it. So again, a lot of these features appear in gaming, where children can, log in and create their own profile and make the avatar look like themselves, or pick the avatar's hair color and all those things. So we wanted to make changes that would make the person kind of more invested in the game and more interested in the character. Again, they felt things like the missions, maybe as they currently stood, were maybe too long for the engagement of the children. Also things like maybe the map could be more interesting and interactive, and also kind of like look at the colors and the sequencing and the numbers of the missions. Other things that they kind of gave us feedback were things like maybe having some indication of like a clock or a timer, visual schedules, break card, help card options, read aloud. So lots of very useful information on how we could adapt the content. I'm just going to skip on 1 or 2 slides just so because I'm conscious of time. So again, this has brought us around to developing the new Feeling Better. So this is Feeling Better ASD. And in the next couple of months, we're going to be embarking on evaluating the feasibility and the effectiveness of this new intervention. So like you can see, the interface has been given a facelift, and the map is different and kind of more clear kind of colors that are more vibrant and appealing to the hopefully the population. We've taken on board the feedback around the kind of structure of it and the number of modules and their length and all that kind of stuff. So it's shorter modules, but maybe more of them. We've integrated new support options, so break cards, help card, or read aloud. So all the text can be read aloud to the participant. Also a timer to show them how much of the lesson they have left. Things like visual supports to show them how many tasks they need to complete as part of the mission. And then we've also created a series of new videos to try and, so there's, I'm trying to think how many videos there are in total, maybe 7 or 8 videos, but they do everything from what is pain, what is chronic pain, what's pain that goes away easily or pain that might last longer, and then also different understanding of like kind of maybe pain experiences and types of pain relief, or ways that they can methods of distraction they can use if they are experiencing pain, and so on and so forth. So I'll just give you an example of one of the videos that we've created.
What is pain? Pain is when something hurts. Sometimes a part of your body can get hurt. This is pain. In this video, you will learn about pain. Everybody feels pain sometimes. Pain is important, and it's how your body tells you something is wrong. Pain is when you hurt. Sometimes when you ride your bike and fall off it and hurt your leg. Your mum or dad could put a bandage on it and give you a hug to make you feel better. Pain is when something hurts, and sometimes.
So the video continues, but I think you get a sense of like the kind of information that we're trying to convey to the children in a very kind of simplified manner so that it's accessible to them. So as I said, this study is one that we're just about to embark on. We're finalising some of the adaptations to the content. So Rachel is still recruiting if anybody's interested in signing up for that one. So like I said, then we've kind of looked at the chronic pain side of things. And then in more recent times, we've kind of switched to looking at also experiences of acute pain. So one of the most kind of like, I suppose, proven concepts is the use of distraction as a method to alleviate pain experience and also kind of anticipatory anxiety around pain. So I suppose from a behavioral perspective, we see distraction as kind of like environmental enrichment and altering the stimuli for a person. So obviously how we can alter the stimuli in a way that's more positive for them and how they can experience something very differently. And in particular, we were focused on the experience of blood draws. So for children that were attending kind of routine appointments and experiencing a blood draw as part of that, so kind of a needle-related procedure, and how we could look at making that a more pleasant experience. So again, we recruited children, autistic young individuals, and that had or didn't have an intellectual disability, to look at how feasible it was to use virtual reality to support them to access routine healthcare. So this study was undertaken by Conor O'Neill in conjunction with collaborators in University Hospital Galway, so Dr. Orla Flanagan, Aisling Lyons and Michelle Dillon. So obviously without them, this one wouldn't be feasible. So we owe a debt of gratitude to them and also the participants for agreeing to participate. Potentially in a situation where they're going to a novel environment and a stressful situation anyway. So we really appreciate them dedicating their time to research in that context. So we had 22 participants overall that were considered for the study. 21 were randomized into a condition. So basically all participants were sent information about the study in advance of attending their routine healthcare appointment. And on the day they would get information about whether they were randomly allocated to their treatment as usual. So that was the control group, or whether they were assigned to the VR condition. And from there, they were received the treatment that was assigned to them. So of the participants that took part in the active treatment, we had 18 male and 2 female. They range in age from 4 to 16, and our mean age was around 11. Of the participants that took part, obviously in this case, we didn't access any kind of like reports or anything like that. It was a self-report. So obviously all individuals self-reported as autistic, either independently or through their parents. And 50% of the participants self-reported to have an intellectual disability. 2 were mild, 5 moderate, and 3 severe. Sorry. So the measure we used was basically a task analysis for a venipuncture procedure. This was adapted from Mendel et al. So they were probably the only paper that we could find at the time that we undertook the study about that had ever run a study with an individual with autism, and they had run a VR intervention with one adult on the spectrum. So we adapted their their task analysis based on feedback from a phlebotomist in CHI Crumlin. So we'd worked with Crumlin on a previous study using VR blood draws for children without autism, and this was the protocol we had developed. We didn't feel that the protocol changed. It was a standard kind of phlebotomist nurse protocol based on their delivery. We also took other measures. So we had the children themselves, they reported their experience of pain by pointing again to the Wong-Baker Faces Pain Scale. So they indicated to us how they felt. We also took parent kind of proxy reports, so whether the parents felt their child was in pain or if they felt their child was experiencing anxiety or distress. We asked the phlebotomist or the nurse about their satisfaction with the VR and with the overall blood draw, and same thing to parents. We asked them, were they happy with the blood draw and or the VR if they were in the VR condition. Parents also completed a behavioural checklist, so they reported about their child's kind of any changes in their child's behaviour during the blood draw. And then we also asked parents and phlebotomists and nurses about their social validity. So, you know, how appropriate did they feel this intervention was for the population they were supporting. So like I said, there was 2 conditions. So people were either assigned to the VR distraction group or the control condition. So that was their treatment as usual. So treatment as usual meant that the children came in for their routine appointments. They were given what's called amniotop gel. So this is basically a gel that's applied to where they anticipate taking the blood draw from. So usually kind of in the bend in their elbow or maybe on the back of their hand. What the nurse did is they applied the gel and then they put a plaster on, like a clear plaster, for up to 20 minutes. And that was so that the gel could have a numbing effect on the location where the blood draw would take place. This was standard protocol in the hospital for the children that were attending. Particularly, these children were all attending a neurodevelopmental clinic. So that was the standard protocol there. And then after 20 minutes, that plaster was removed. All participants received that. The only difference was that the children, the participants in the control group, so obviously we didn't encourage them to use any method of distraction, but if they did select to use any method of distraction, we just took note of what they did. And then for the children in the VR distraction group, so they had the same amniotop gel applied, the plaster applied and then removed, and then they received a VR distraction in the form of the Ocean Rift through a Meta Quest 2 device. So for some people, I know that's all probably a little bit gibberish, but I'll explain. So here's some still images of Ocean Rift. The participants, when they took part in this study, saw images like the upper kind of panel, so they could see the coral reef in the Ocean Rift, and also the sea turtles was the scenes that we selected for them to enter. There's other scenes within Ocean Rift, like kind of mammoths and things like that are manatees that they can see and swim with, and sea lions, and the device is shown in the lower right hand corner, so that's the Meta Quest 2. So just for information, this was the link that I said we'd post in the chat. So it was just if you want to see what it looks like when they're wearing the headset, you can watch part of this YouTube clip. So from 4 minutes and 10 seconds to about 4 minutes and 39. That's kind of represents the kind of sea turtles underwater scene. So you'll hear it is accompanied by kind of like audio. And when you're in the VR headset, you're fully immersed. So you can't see anything outside you, and you can just hear and see this content. So it is quite immersive. Here's some still images of the participants that took part in the study. So as you can see, everyone's very relaxed, having their blood draw while wearing the VR headset. We were really happy to see the effects of it. So we found that participants in the VR distraction group actually reported lower pain scores on the Wong-Baker Faces Scale. Obviously, we had our own reservations about how accurate this data might be, but we found that when we took the task analysis data, that actually we also found less avoidant behaviour. So obviously participants completed more elements of the task analysis successfully, and all participants in the VR condition had a successful blood draw during their appointment. Also, we didn't find any difference on the parent behaviour checklist during it, or child distress as measured by the parents. But parents and phlebotomists did report high levels of satisfaction with the VR. Again, participants reported that they were totally satisfied and enjoyed wearing the VR headset. We would have identified from the data that we have to date, though, that individuals with lower support needs felt like, they would enjoy a game that was maybe more interactive. But obviously we had selected this game that it was passive and that we could ensure that their arm remained still during the procedure. They didn't actually use the controllers. We had set up the game in a way that it was already set up, and when they put it on, they were already in the environment. They didn't have to like click in on anything to access the game. Whereas individuals with higher support needs, they really enjoyed the game, and their families felt it was very appropriate to keep them engaged and to hold their attention for the duration of the blood draw. We did find some interesting other supports that may be of benefit. So we found that some of the individuals might actually benefit from having like a verbal commentary read out, or I suppose verbalized to them throughout the procedure. So obviously when they put on the VR headset, they can no longer see what's happening around them. But obviously the blood draw is still proceeding. So very clear information being provided to them about I'm just going to hold your arm now and the needle is just going to go in now. So they still really wanted to know what was happening in the outside world, so to speak, while they were wearing the VR headset. We also found that the children still enjoyed or benefited from having close contact or physical contact with their parents. So either still holding their parent's hand or being allowed to sit on their lap, or having them at very close proximity to them while they were wearing the VR headset. And again, like I said, parents indicated that they were overall satisfied with the VR and its use during the blood draws, and similar results for the nurses and phlebotomists. So they found it a very appropriate method that they could integrate as part of their routine care. So again, I think these findings, although they've answered some questions for us, they've left us with a lot more questions, and we hope to continue this strand of research to look at how we can ensure that VR might be something that it becomes part of standard care for all children once they're attending to receive blood draws at hospitals. So that brings me to the end of the information that I have to share with you today. So as I said, a huge thank you to all those that have been involved, particularly Rachel and Connor for leading out on some of the studies that we've undertaken to date. And I've just enclosed some information if people want to reach out to us if they're interested in being involved in any research collaborating between pain and behavior analysis. We'd be really happy to hear from people. Thank you.
Helena, that was absolutely great and a really amazing talk and really vital research. I think if we are talking about inclusion, about access to basic rights, having your medical needs met doesn't get more basic than that. So that's really, I think everybody was probably riveted listening to you and be so interested to hearing more things. I'm going to just allow people to post any questions they have on the question and answer section. But in the meantime, as you were talking, what really struck me was the implication of not assessing pain correctly when you're talking about the impacts of pain on sleep, on mood, on concentration. I'm thinking about the settings that I've worked in, how often, especially maybe people living in residential care, have this kind of wealth of often medical interventions being administered, especially around sleep, around behavior, when actually if we haven't assessed pain at the very basic level, how often these are going to be actually really huge barriers to compassionate and proper care.
Yeah, and I think it's quite interesting, and I think it's probably a very simple adaptation a lot of us could make, when we're undertaking our standard functional assessment. It could be a tool so the NCCPC could be something that's just embedded to say, is pain something that's present for this person? Do we see indicators so that it could at least be screened for? And
Yeah.
then it could be something that could like warrant either, a follow-up, like a medical referral. Because I think sometimes when we take on referrals, we're like, is there a need for a medical referral? And I think it's a little bit challenging sometimes when we don't have something to kind of guide our decision on that. So I think having a tool such as that, and particularly if individuals are scoring and meeting the threshold for either mild or moderate pain, can be a good indicator if we need to pursue something in that area.
Yes, certainly. I think you mentioned as well that you had asked in your kind of initial study what method parents were using, and they're mostly relying on observation of behavior change. Did you see any other methods more systematic in maybe educational settings or care settings?
No, we found like that. I think the biggest thing is people were saying they didn't have an appropriate methods, and some people didn't have a formal, like they weren't using one of the measures, like the tools that we had identified in our systematic review. They were actually just relying on, we see more of these behaviors today, or we're seeing more challenging behavior today, or some indicators, so more grimacing, or maybe more reluctant to, so they might engage in like less movement and things like that. So it was a lot of like behaviors being interpreted by the people around them, do you know what I mean, and interpreting them correctly, and that was probably the greatest challenge.
Yeah. Great. Just a kind of a technical question for the VR applications, and potentially that came up in your teaching components as well. Did you have to do a lot of work around desensitization of touching body parts in when they were getting, maybe requesting, certainly in the blood draw, looking at they couldn't see, but people touching their arms, or maybe the touch of the needle on bodies, or also desensitization around taking pain relief?
Yeah, so I suppose they're different probably for the two studies. So the VR one, a lot of the children that were coming into us, so some of them had actually already had a blood draw. So I think they had an expectation and an understanding of kind of like what it entailed. Unfortunately, for some of them, that wasn't necessarily something positive. So some of them had more higher levels of anxiety. Do you know what I mean? And actually, we did take some data on the number of, so there was some instances in the treatment as usual condition where actually it took 5 staff to restrain someone to receive their blood draw, whereas in the VR condition, we had no physical intervention at all required in order to safely administer the blood draws. So I think it did require less physical contact for the individuals supported. So I think that was probably a positive thing. There was some requirement for them to like maybe become familiar with the VR headset and maybe being comfortable with having it put on and taken off them. But we wouldn't have had any huge resistance to that. A lot of them were quite interested and curious about exploring it. In relation to the other candidates that were like experiencing, say, routine daily pain, it was very individual in relation to kind of their own responses around pain, whether they were sensitive to touch and things like that. But in most cases, if assistance was being offered to them, they were quite happy to receive it. But obviously, if they were in a lot of pain and didn't want something touched that was a painful part of their body, we would see similar reactions that we would expect. You know what I mean? So they would recoil from touch or things like that.
Yeah. Lastly, where would you like to see this, or how would you like to see this research being used or implemented, and especially what settings?
Yeah, well, we would like to see the kind of online intervention. So we'd hope that like after the study that we can find a mechanism to ensure that it's kind of freely available to everyone, so that once we've evaluated and we know that it's effective and that the adaptations that we've made to it are useful, we would like to have it hosted as a kind of a free treatment option for people. And also, I suppose the VR stuff, we would like to see it kind of become more standard practice in hospitals. So the hospitals we've been working with, so like I mentioned, so we'd previously done some work with Crumlin's Children's Hospital in Dublin, and also with the hospital here in Galway. And I suppose part of the challenge is that we've done the studies, we've shown they've been really successful, but after the study is finished, it's difficult to get it to be delivered in an ongoing way. So I think it's about ensuring that we work with the hospitals to look at, you know, who takes on the role of delivering the VR to patients once they visit the hospital. So is it the nurses? How can we train them all to problem solve the technology challenges that might arise with the VR? So there's certain things you have to do when you turn on the VR. You have to set the boundary and you have to select the game and all that kind of stuff. And our nurses in a situation that they can take that on, or in some hospitals they do have play therapists. So I think it's one, establishing whose role it will be to deliver the treatment in an ongoing basis, and two, ensuring the hospitals have the kind of right access to like the right resources to buy the equipment that is appropriate and the games that are appropriate for the children to use during blood draws and procedures such as that.
Yeah, it's fascinating. It's not hard to see why your publication got so much interest, and a huge congratulations to you and your colleagues. And I think we'll be really eager to hear how the study pans out.
Yeah, well, Rachel's nearing the completion of her PhD, so hopefully we'll see a few more publications in that area to make sure that this kind of information is as widely available as possible. So
great. Well, thank you so much, Helena. That was really great.
No problem.
I think we